So, good afternoon and welcome to all the dignitaries present here. I am Shweta from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as a digital partner for this event hosted by National Neonatology Forum, Gujarat, and the focus of today's session is on post-discharge nutrition management and growth monitoring in preterm babies. So, without any further delay, I would like to hand over the session to you all. Over to you. Kindly proceed. Thank you.
Thank you, Shweta. So it is a great pleasure to invite Dr. Nitasha. She is going to take, as we are taking preterm nutrition in this month, she is going to take on the post-discharge formula and the growth monitoring. Before that, I would like to request Shweta ma'am to say a few words.
Thank you, Kunal. Thank you so much, Dr. Nitasha, for taking up so extempo session on post-discharge nutrition of preterm. I'm really very happy to have you on this platform of NNF Gujarat. I would like to ask our EB member, Dr. Monish sir, to introduce Dr. Nitasha ma'am.
Thank you, madam. Welcome, Dr. Nitasha madam. Madam has done his DNB Pediatric and Fellowship in Neonatology and Consultant Neonatologist and Pediatrician at Rainbow Children Hospital, Banjara Hills at Hyderabad. Her research publication to her credit is she has 10 indexed medical journal, 8 chapters in textbooks, and editor for the 3 indexes in medical journals. Her area of interest is preterm nutrition, breastfeeding, human milk banking, and quality improvement initiative, establishment of the human milk bank in the corporate setup. She is involved in training PG students, DNB Pediatric and Neonatology, and NICU Nursing Fellowship Program. She is a speaker and moderator for several conferences, CMEs, and workshop. Welcome, madam, for the behalf of NNF Gujarat, and we can start your talk now. Thank you.
Thank you so much for the introduction, doctor. And at the outset, I would like to thank Gujarat NNF for giving me the opportunity to talk to students all across, all the way to Gujarat. So I will be not taking much time of you and start the topic straight away. So today the topic was post-discharge nutrition in preterms. I would just like to modify this sentence saying the post-discharge nutrition for at-risk neonates. So what do you... So the learning objectives from this talk is because post-discharge nutrition is not only required for the preterms, it is also required for those who are late preterms, also required for those who are term babies, but at risk of various things. So learning objectives from my talk would be who are the at-risk neonates, and why do we need to focus on to the post-discharge nutrition period for the growth and nutrition? And why does the post-discharge growth faltering actually happens? Post-discharge nutritional supplementations and the growth assessment. So we will take one by one. So at-risk neonates are those who are premature, any baby who is less than 34 weeks of gestational age and or less than 1.5 kilo at birth. All the babies, those who are born late premature, are considered to be at-risk neonates, and any infant who is born IUGR or small for gestational age, whether it's a term baby or a preterm baby, is considered to be at-risk neonate. So we will be studying about the post-discharge nutrition and the growth monitoring of these neonates who are at risk. So we all should understand one thing, that preterm birth is a nutritional emergency. NICU must focus onto the nutrition because intake in the NICU affects the growth and the long-term health. Protocols are needed to guide the nutrition, and highly variable nutritional practices in the busy NICUs can produce variable growth outcomes. Because we all know that every NICU practices differently. Every consultant has got the different protocols. So that is one of the very important reasons for having growth faltering in the NICU. So if you can see here, we have got three phases of any preterm baby who is in the NICU. One is the acute phase where the baby is admitted. Second is the convalescent phase, and third is the discharge. So acute phase is immediately after. So the needs of the nutrition of any premature baby is different during the acute phase. The needs of the nutrition during the phase 2, that is the convalescent phase, that is after the first 1 week of life, when the baby enters into second or third week of life, and the discharge nutrition. So these are all three different areas of concern as it comes to the preterm nutrition. So we are going to discuss about it's not moving. So we are going to discuss about the post-discharge nutrition in our presentation. So if you see, the faster growth is linked with the better neurodevelopmental outcome. This is nowhere I'm talking a new thing to you. We all know the better the growth of the baby, the better will be the neurodevelopmental outcome in the premature babies. And reasons for so what are all the reasons for the poor post-discharge growth? Why the babies do not grow good when they are discharged? So there are many reasons behind it. Inadequate feeding due to the poor suck and swallow. See, we all discharge our babies at 34 weeks. Most of the NNF guidelines say that we discharge our babies somewhere around 33 to 34 weeks, maximum 35 weeks. So they are having a poor suck and swallow, so which the parents are not able to understand. That's one of the reasons for the poor growth. Inadequate breast milk at the time of discharge, because the mother is in the transition phase. She's at the time of discharge and is not able to have an adequate breast milk. So much of stress she has. So inadequate breast milk. The babies till 34 weeks were under the warmer and has been suddenly come out of the warmer and have been sent home. So cold stress. Exaggerated anemia of prematurity and another reason for the poor growth in the post-discharge babies. Inadequate calories and the protein due to stopping of fortification. So we all have been giving fortification inside the NICU because we give express breast milk and mixed HMF or MMF into it. But once the babies are discharged, we always try to encourage the mothers to start direct breastfeeding. So we have stopped the fortification, and so the inadequate calories and the protein intake causes one of the reasons for the post-discharge nutritional delay. Sepsis and sickness in the baby is another cause. Electrolyte imbalance can happen, like late onset hyponatremias, which are usually goes unmonitored, because not every premature baby after going home comes back for the follow-up visit. KMC is another very important thing. So when their babies are there in the NICU, each and every baby we are so much obsessed about the KMC that all the consultants, all the NICU fellows, nurses will be behind the mother to do the KMC. So she will also feel motivated. But once she goes home, there are a lot of other problems which the mother faces, and there are a lot of other responsibility which the mother has. And she has to feed, she has to do the diaper change, she has to give bath to the baby, she has to do everything. So the KMC gets lagged in the post-discharge period. So preterm infants are discharged before reaching term-corrected age and before the breastfeeding is established. Volume of feeds at discharge varies greatly with the variable caloric content. So these are, if you just understand this slide, you will all understand why the post-discharge nutritional delay happens and why the growth faltering happens once we discharge the babies, and why this period is very, very important to monitor all those things so that we can prevent the post-discharge malnutrition in the babies. So there is a consensus on the preterm infants' nutritional requirements. The data available on the preterm infants' optimal nutritional management following hospital discharge are limited. So there is a need of individualized approach based on the clinical entity and velocity of the catch-up growth. There may be a window for catch-up growth in the early post-discharge period. If you see, this is the time period where they actually, so till they are inside the NICU, we all do the nutritional calculations. We give them a calculated calories. We give them a calculated nutrition. As soon as they are discharged, they do not come for the follow-up. So this is the window period where the growth faltering happens. And this is the early post-discharge period, which we really need to catch. So meeting the nutritional goals while being mindful of important changes. Few potentially best practices I will talk about, which needs to be taken care of in the post-discharge period. So practice one, we all know, promote human milk feeding. The multiple benefits of breast milk and breastfeeding should not terminate at the hospital discharge. We all stimulate the mothers about the human milk feeding. That is important. We should continue doing the same at the time of discharge. Exclusive breastfeeding without supplementation at hospital discharge is not the primary goal for most of the extreme, very low birth weight infants. The duration of human milk feeding is significantly longer for those who transition to home breastfeeding in the hospitals. Mothers should be advised to continue to express milk using a hospital-grade electrical breast pump after breastfeeding to maintain milk supply for at least 1 to 2 months post-discharge, or until the infant is transitioned over the direct breastfeeding. So what does this slide tells us? It just tells us that we have to promote human milk feeding after discharge also. So an appropriate counseling of the mother should be done, that why the breast milk is important even after discharge. Any baby who is born low birth weight or very low birth weight babies need to be transitioned up to 1 to 2 months till they reach term corrected age. The expression of the milk is very, very important for the mother. No doubt, if the baby is crossing 2.2, 2.3 kg, we can consider direct breastfeeding. But if it is still lesser than that, make sure that the mother expresses the milk and feed the baby. The concept of triple feeding, that is breastfeeding, supplementing with the previously expressed milk or formula, and then pumping. It is very, very important and very, very useful. You can tell the mothers to do the triple feeding. That means they can also express the feed. They can also directly breastfeed, maybe 2 feeds as breastfeeding, 2 feeds at expression of the milk, and 2 feeds adding the supplemental or the formula feeding. Skin to skin care should be continued post-discharge home. Test weighing can be continued at home with the rental scales if the mother wishes to do so. Fortification should be added to each supplemental feed of expressed breast milk, or we can have 1 to 4 feedings per 24 hours of the prescribed supplemental formula with otherwise unlimited breastfeeding. Should be fed with exclusive breastfeeding, mixed feeding in case of the insufficient amounts of the breast milk, or standard infant formula, which is enriched in long-chain polyunsaturated fatty acids. Always remember, formula feed is only and only recommended if the mother's own milk is not available, or she lacks, or she has an insufficient amounts of breastfeeding. There is no replacement of the breastfeeding. We have to stimulate the mother to encourage the mother to have exclusive breastfeed. But there might be so many mothers who are lacking short of the milk. They should not be going home without any other supplemental formula. They should be given an option of the supplemental formula if it is not available. So this I'm talking about those who do not have any extra uterine growth retardation. That is the growth retardation which is a part and parcel of any premature baby. So those babies can be given option of breastfeeding, mixed feeding, or even if the standard infant formula, if the mother's milk is not there. But in case of the babies who are at the risk of EUGR, who are already having extra uterine growth retardation, or at the risk of long-term growth failure, they should be fed with the fortified human milk or the formula milk adapted for the preterm infants. In those cases, we should not let direct breastfeeding go in. We should express the mother's own milk and mix it with the calorie-dense fortifier, which is very, very important to catch up the growth. So this is what I was talking about. This has to be an individualized approach. The second practice is based on the growth history and the selective nutrient deficiencies as well as the current needs should be employed for the post-discharge nutrition of the preterm babies. At-risk neonates at discharge will almost always require some additional nutritional intervention beyond the term formula or the human milk alone. You have to remember that this is one of the very missed in the sense of promoting exclusive mother's own milk. We sometimes forget that there are babies who are at risk of having a post-discharge growth delay. So if the mother's own milk is insufficient, we should always have a replacement of the calorie-dense formula which is available. So in India, the available options is Similac NeoSure, which has got 22 calories per ounce and can be easily considered as one of the important interventions whenever mother's own milk is not available or is less in quantity. Possible post-discharge feeding regimens, you can have those who are on appropriate for growth and normal laboratory findings. We can give maternal milk as well as oral vitamins and the iron drops. Those who have got the slow growth and benign labs, they will have maternal milk along with the post-discharge formula. And the babies, those who have got a slower growth with the abnormal bone labs, they should be significantly given the post-discharge formula at least 2 feedings per day, along with the vitamins, iron, and the calcium supplements. Where we have got an inadequate maternal supply of the milk, there we should supply with the post-discharge formula as and when needed. Whether it is available of 22 calories or 24 calories, we should try to supplement as maximum as possible after the maternal milk supply is over. According to the SFEGAN guidelines, formula-fed preterm infants should receive special post-discharge formula with high contents of proteins, minerals, and trace elements, as well as long-chain polyunsaturated fatty acids. until at least post-conceptional age of 40 weeks or until 52 weeks, depends upon how the growth of the babies. If the catch-up growth is good, we can stop the supplemental formula by 40 weeks. But in case if it is still on the lower side, it is recommended to continue till 52 weeks. Continued growth monitoring is required to adapt the feeding choices to the individual infants. Just a second. I'm sorry. So various micronutrient supplementations, I think this must have been already covered in your enteral nutrition guidelines, but I'll just touch brief on the post-discharge micronutrient supplementations, which are usually missed by the parents and are very, very important. Iron, zinc, vitamin D, calcium, phosphorus, and long-chain polyunsaturated fatty acids. So recommended dietary intake of iron is 2 to 3 mg per kg per day in the babies who are birth weight of less than 1500 grams. Those who are between 1500 to 2500 grams, 2 mg per kg per day. And those who are more than 2500 grams, around 1 to 2 mg per kg per day for the infants. Iron requirement tailored according to the birth weight, degree of prematurity, and type of feeding and level of hemoglobin and the ferritin levels. So we have to make sure that we should be giving somewhere around 2 to 4 mg per kg of iron and try to restrict the iron up to 4 mg per kg per day. Very low birth weight babies, particularly if breastfed, the dietary iron intake must be increased to 3 to 4. We can go up to 6 mg per kg per day in the very low birth weight infants. One of the things which has to be monitored during the iron supplementation is ferritin levels, even after the post-discharge. Remember, this is one of the forgotten things during the post-discharge. So when these babies come to us during the post-discharge period, we usually do not measure the ferritin levels for them. During the NICU stay, yes, we do that because we are giving blood transfusions, we are giving iron supplementation, but usually it's a forgotten policy. So at least once in 3 months to 6 months, ferritin levels are important to be measured. If the ferritin levels are more than 300 microgram per liter, which can be a common finding after blood transfusion, iron supplementation should be postponed. So the take home is start at 2 to 4 weeks of life and continue till 12 to 15 months of age. That is the iron supplementation. Zinc, regular intake of zinc is critical as no appropriate system for storing or releasing. Zinc content gradually decreases through the first month of lactation, ranging from 8 to 12 milligram per liter in colostrum to 1 to 3 milligram per liter at 1 month of life. So zinc concentration in the preterm human milk significantly lower than in the term milk through the first 2 months of corrected age. There are no accurate biomarkers available for the zinc status. So the current need which is going in through the formula fed babies is 1.8 to 2.4 mg per kg per day and 2.3 to 2.4 mg per kg per day in the breastfeeding infants. So again, the take home is start zinc at 2 to 3 weeks of age and continue till 12 months of age. Coming to calcium and phosphorus, as we all know, the calcium, according to the American Academy of Pediatrics, 140 to 160 mg per 100 kilocalories and 70 to 140 per 100 kilocalories, according to the ISFIGAN guidelines. Phosphorus need is 95 to 108 mg per 100 kilocalories and 50 to 86 according to the ISFIGAN guidelines. Serial measurements of the serum calcium, phosphate, alkaline phosphatase, and parathormone and vitamin D are not recommended post-discharge. Remember, I'm talking about the post-discharge and not during the NICU stay. In very low birth weight babies, bone metabolism biomarkers by 2 to 4 weeks post-discharge are suggested. Alkaline phosphatase of more than equal to 800 to 1000, calcium phosphate supplementation should be initiated or increased post-discharge period. In case, if at all, we do the test and we notice alkaline phosphatase is on the higher side, we should increase the calcium and phosphorus supplementation. Growth faltering infants should be supplemented up to 6 months of age with the calcium and phosphorus supplementation. Breastfed preterm infants reach adequate bone mineralization only at 2 years of age. So we have to remember and keep on checking on intervals and not onto the regular basis. Like in the NICU, when these babies are there, we do the regular, maybe after 1 week or 2 weeks, we do the calcium, phosphorus, alkaline levels, but after discharge, maybe once in 1 month or 3 months, they are required to be checked. And if they are going on adequate, we don't need to check them post 3 months. But growth faltering can happen up to 6 months of age. So we have to be very, very cautious till 6 months. Coming to vitamin D, again, a very common and favorite topic of all the postgraduates, recommended to start within few days of birth. We usually consider it 5 to 6 days of life. Once we start establishing breastfeeding, at least 80 to 100 ml per kilo per day. Isfahan recommends, this is according to the previous guidelines of Isfahan, but remember that currently Isfahan guidelines recommend 400 to 800 international unit per kg for all the VLBW infants and 400 international units post-term gestation. So any baby who is discharged and has crossed term gestation will be given only 400 international units per international units. Serial measurements of vitamin D are not recommended post-discharge unless there are any specific risk factors identified. Like if at all you have got a low calcium levels, low phosphorus levels, or you have got a high alkaline phosphatase. In those cases, vitamin D measurements are recommended. Vitamin D supplementation is recommended at least up to first year of life, whether it's a premature baby or it's a term baby. Serial measurements of long-chain polyunsaturated fatty acids, particularly DHA and arachidonic acids, are not recommended based on the well-documented benefits of PUFAs in preterm infants, and considering the described deficiency in premature babies, it's useful to supplement DHA in the premature babies. This could be achieved both through the use of dedicated supplements or in the absence of breast milk through DHA-enriched infants formulas. As I have been talking to you about the post-discharge formulas. Obviously, we do not have any such supplement which contains only long-chain PUFAs to be given to the baby. So breast milk, whatever is the consistency of the breast milk, it goes in. But in case of deficiency of breast milk, wherever we use the preterm discharge formula or post-discharge formulas, we should make sure that the content of long-chain polyunsaturated fatty acids is present in that. DHA supplementation may be advisable, but there is no sufficient evidence to advise specific timing and dosages of the DHA. Coming to the multivitamin, those to deliver at least 1500 international units per day of vitamin A, 20 to 70 milligram per day of vitamin C, and 400 international units of vitamin D should be added at the time of discharge. B vitamins are also necessary for the former preemie receiving unfortified human milk. A multivitamin preparation dose at 1 ml per day will usually supply all the above. So any of the multivitamins which are available, whether it's B1 drops, ZND drops, or the Zinc drops, whatever are the multivitamin drops are available in the local region will be supplying all the above vitamins in the given quantity. If formula constitutes more than 50% of the infant's daily intake, the dose should be 0.5 ml per day. You can still supplement with the multivitamins. So take home is multivitamin administration should be continued for at least 3 to 6 months post-discharge. I will not talk much onto the complementary feeding over here, but I would just suggest that complementary feeding should be started 5 to 8 months of the chronological age, taking into account the limit of 3 months or to 4 months of the corrected gestational age to ensure the acquisition of neurodevelopmental skills, which allow consumption of the solid foods. Type of foods, sequence, and speed of introduction will be same as that of the term infants. Along with the sources of carbohydrates, proteins, and fats, although whether attention should be paid to the intake of micronutrients, example, iron and vitamins, but otherwise all the protocols are as same as for the term babies. The only thing is we should be starting the weaning or the complementary feed 3 to 4 months of the corrected age so that the developmental milestones have been achieved. Growth as a measurement of nutritional status. So we all have said that, okay, this is important, that is important. We have said that human milk is important. We have told about what are the various additives we can give to the post-discharge babies, like post-discharge formulas, post-discharge multivitamins, post-discharge calcium, phosphorus, vitamin D. But a very important factor which I always convey to my postgraduates is unless you monitor the growth of the child, we will not be able to understand the nutritional status. So growth measurement following discharge is very, very important. So minimizing the disability at the risk babies, the follow-up of the growth of the preterm babies is important. Neonatal intensive care cannot be practiced without follow-up services. The objective is to identify early deviation of growth and development from normal and provide the nutritional support and intervention as indicated. You can have maybe 1 out of hundreds or thousands of such babies who will be having growth faltering, but it will be identified only and only if you do a proper growth monitoring. So what do you measure in the growth monitoring? The weight, the length, and the head circumference are the common anthropometric measurements which you can do. The weight should be around 16 to 18 gram per kg per day. And we all know length should increase 1 centimeter per week and head circumference also around 1 centimeter per week. Growth charts over the target goals. So sometimes the question arises, which growth charts are preferred? Targets can change. So usually what happens is, we have two things. Sometimes we just want to just say, okay, my patient is having 16 to 18 grams of growth per week, so I don't have per kg per day, so I don't have to worry. Baby is growing 1 centimeter and baby is in the length and 1 centimeter in the head circumference. But I would say always plot the growth charts. Even if you lack short of time in the OPD, make sure you have somebody along with you who is plotting the growth charts. It just takes half a minute extra to plot a growth chart. Because growth charts are preferred, targets can change with the corrected gestational age. We have to remember the growth of the baby who is immediately post-discharge after 34 weeks. The targets of growth for that baby is different from the baby who has reached 40 weeks and the baby who has just 52 weeks. So growth charts are important to be plotted, and targets are dependent on whether one is in the 90th to 10th centile of the growth. So that's also very important. So then the question comes, we know that the growth charts are important, which growth chart to use? 20 to 50 weeks postnatal age, we use the Fenton's growth chart. And intergrowth 21st can be used 27 weeks onwards, and we can use it till 64 weeks of the postmenstrual age. I'll give you a small example. So this is the baby who was born extremely low birth weight, 710 grams. So this was the birth weight of the baby who was born at 25 weeks of gestations. If you see, this baby was discharged at 33 weeks of gestation and was 1.2 kilo at the time of discharge. If you see, the post-discharge weight after 4 weeks of post-discharge was still 1.2 kilo. That is at 37 weeks. So this 4 weeks of the post-discharge period can bring a lot of problems in the long-term neurodevelopmental outcome of these babies. So don't take your eyes off the ball. It is very, very important to have a post-discharge. So this is what, if we plot a growth chart, will give you that the growth of the baby is almost static at the time of discharge. So there was a good growth of the baby during the NICU period, and this is the time when you notice that there is no growth. So there is a growth faltering. If you start your interventions, you can still have a follow-up growth chart which is as normal as any other babies. So don't take off your eyes. This is the most critical period for the growth failure. That is the immediate post-discharge period. So WHO growth chart from 0 to 5 years for boys and the girls can be used. So this is another very important tool which I believe in a lot, because education of parents at the time of discharge and follow-up discharge counseling makes a huge difference, because a general people cannot make out the difference between what is a preterm baby after discharge or a term baby after discharge. They just consider that the baby is discharged, so this is good to go, so not to worry. But this is not the case. So for the preterm babies or at-risk neonates at the time of discharge, their growth monitoring, their follow-ups with the pediatrician, their follow-ups for the growth and nutrition is very different than that of the term babies. So parental teaching and practice about the competency prior to the discharge, it is very important. Feeding tube or the pump, breast or a bottle feeding, development of the oral feeding skills for the baby, promote breastfeeding and monitor for the fortification needs. So these are very important aspects. Nutritional discharge planning should be individualized, comprehensive, coordinated, and include appropriate nutrient fortification and nutrition follow-up. Mothers should be encouraged to eventually achieve exclusive breastfeeding after discharge while ensuring appropriate growth for the infant. Monitor infant's growth, including weight, length, and weight for length and head circumference every 2 to 4 weeks after discharge. Once stable, monitor every month, then every 2 months about the growth of the baby. So few take-home points: exclusive breastfeeding without supplementation at hospital discharge is not primary goal for very low birth babies. That means we have to make sure that supplementation has to be given. It is not only exclusive breastfeeding for the preterm babies. Iron supplementation should be continued till 6 months to 12 months of age. Vitamin D supplements should be given at least till 1 year of age. Multivitamins should be added at discharge and should be continued till 3 to 6 months. Provide realistic time-like guidelines and frequent follow-ups of the baby. I will also not say that you should call every 48 hours or every 3 to 4 days follow-up. Give a realistic follow-up, like maybe a weekly follow-up till your baby becomes 2.5 kgs, and then after that monthly follow-up for the vaccination visits. So some realistic follow-up time is very important, which should be given to these premature babies. Premature infant development follow-up clinics should include both nutritional and lactation expertise if possible. So these are the different growth charts and the different tools with which you can download when you're sitting in the outpatient department. You can do the growth chart monitoring for the babies. Goals to nourish preterm infants after discharge: promote human breast milking, milk feeding, minimize nutrient deficits, promptly address the identified deficits, avoid overnourishing. This is again a very, very important point. Lot of mothers I have seen, once they go home and the mother's milk is not sufficient, they give more than what required the post-discharge formula, and they use a hue which is rich of high calorie and high protein, and that causes overnourishing and can lead to the obesity of these premature babies. So overnourishing also has to be avoided. So unlock your potential. There are no secrets to success. It is the result of preparation, hard work, and learning from failure. And this is Department of Neonatology, my team, who take care, and my team of nurses who have been taking care of the nutrition when the babies are there inside the ICU, and then counseling the mothers when they go post-discharge home. So that's all from my side. Thank you.
Kunal?
Yes. So thank you so much, ma'am. It was a wonderful session, and as there are few insights of the post-discharge, also there are important points which you have highlighted, which are very important for all of us to practice, like taking care, regular follow-up, adequate post-discharge nutrition, multivitamins and all, vitamin D, iron, which needs to be regularly given to all the babies. These small points are there, but it has an impact for the life for the preterm baby which we are surviving. So thank you so much for the insights which you have given. Some of our EB members and all have joined. So I request if anybody have any questions, they can ask. So with due permission of Shwetal ma'am, there are no questions are there, so we can conclude this session. Thank you so much, Shah ma'am, for an excellent talk. Thank you, Shwetal ma'am. EB members like Dhiren Bhai and all have also joined. Thank you so much all. Thank you, Clearlit, for the seamless experience and being our partner. We hope to meet you all again on next Wednesday for our case presentation on which will be related again to preterm nutrition. Thank you.
Thank you
Shweta.
so much, Nitasha. Thank you so much, Nitasha, for an extempo external presentation. I'm sure PGs must see what we consultants tell them in the rounds is again reinforced by you with evidences and practical tips. So there will be a great learning message to all the PGs. Thank you so much, Natasha. Thank you.
Thank you. Thank you.
Shweta, we can conclude now.
Yes, sir. Thank you so much, sir, for giving us the opportunity to host this session. I hope you all had a similar experience. So, sir, with all your permission, can we conclude the session over here, sir?
Yeah, sure.
Thank you so much, sir. Thank you.